Dr. Menen, if you would care to lead off and tell us about the St. Peter Hospital approach to care transitions.
So I guess first of all, I'd have to say when you said distinguished panel, I almost turned around because I thought I had the wrong place. So I have to say I'm glad that Carol gave her overview because it kind of reminds me, through my own personal history in this process. When I came here about 2.5 years ago, and one of the first things that, as the new chief medical officer, they made me aware of is we have this readmission committee, and they wanted me to be a part of the readmission committee. And this was a cohort of many different types of people, nurses and therapists and coaches and navigators and physicians and palliative care and you name it. I think there were probably 30 or 40 people associated with this committee. And so I said, first thing, well, what are you trying to do? Well, we're going to reduce admissions, readmissions. I'm like, great. How all readmissions? All readmissions. It was like somebody opened a fire hose on me. I mean, we had all these things. We want you to do this. We want you to call patients. We want you to give them materials. We want you to go to their house. We want you to, make sure they get to see their doctor in 3 days. We want, good communication. Everybody gets everything. And I said, well, great. Well, what are your resources? Oh, we don't have any. What's the reimbursement for all these things that we're going to give? None. But we're going to save because readmissions are going to be penalized. Awesome. What are you going to save? Nothing. We're 2% less than the expected rate of readmissions. So, this is, I have to say, one, an ocean of a task. And the literature, if you look out there, is full of this and what people have done. And reflective, I think, of what Carol talked about before is her 3-year project, I think, is echoed in many places. People have tried enormous educational programs, computer programs, multiple things to educate their patients before they leave the hospital. They make a small impact, they're never sustained, and they're incredibly costly. They go to their house. That's a very good process, but incredibly costly and hardly any resources. There's a great story about a guy in Phoenix. Hospitals employed him. He has a van. He literally goes to people's houses. Very effective, but how many people can this guy see in a day? The problem is enormous, and if you look across the country, and I don't care if you go to the premier hospital, success this way has been fairly poor and non-sustained and incredibly costly. And so in that process of looking at this, and I also want to mention another thing that I have found out, to dispel some of the myths of how this process works is, okay, they say, call your doctor and get within 3 days. I mean, I was in private practice for 10 years. I mean, I was booked 2 months out, I didn't, just like you, as a cardiologist, I didn't even know my patients were in the hospital. They'd come back and see me. I'd see them in clinic. I was in the hospital. How come you didn't come see me? Well, I didn't even know you were there. And that is a common occurrence, and I agree with you as a fault. But, the first couple of times when I was started in practice, I would call people to tell them, hey, I just saw your patient. I'm going to discharge him. And I would be interrupting their 30-patient day, and they would say, well, is he fine? Well, why are you calling me? Why don't you just send me a note? And so everybody's individual that way. I call and I get the phone tree, so then I wait for that, then I get somebody, then I get somebody, then I get somebody. And so I call it admission, I call it discharge. I'm seeing 18 patients a day, 5 patients in the hospital, 3 admissions, couple caths. When am I going to call? There are certain practicalities about this process, and people have said see patients within 3 days. Okay, You know, the studies, every single study, and I've read probably 10 of them that have looked at this, people who see their doctor within 3 days, first of all, you raised a phenomenal point. How many of you have done hospital medicine? I mean, these patients, even though you know them, without having been in the hospital for 5 years, it's incredibly to know over the phone, well, this is a serious problem, this isn't a serious problem. And I've got 2 minutes and 3 patients are already, 15 minutes behind. So the process itself is enormously complex. I'm just telling you as I have seen it and also participated in it. So what to do with this process? I mean, I don't think we're going to cure the whole thing by any easy plan or just by throwing enormous resources, because we can't do it. So my suggestion to St. Peter's, and what I have been driving for, and what I've spoken to some people here about, is what bits can we chew off? We have a hospital navigator, and I can tell you, going back to the amount, we in the entire system as year to date so far are dramatically lower in our readmissions than the expected rate. In Western Washington, no Providence, I'm not privy to the other hospitals, but no Providence hospital is even coming close to getting penalized for readmissions from the government. So we're, I think most people would say that's a pretty good job. So driving it is simply because it's the right thing to do, because what you guys have mentioned to me, I do see, not the majority of the time, but some of the time, patients going home with the wrong medications or double the medications. And why does that happen? And what happens is they get to the hospital and we have our formulary because cost pressure is incredible. In addition, we have the state saying generic medicines, generic medicines, generic medicines. So we shift them around and they get all these new medications because we get ginormous cost savings from this. And you've got 32 hospitals. It's hard to say, we're going to give you your benazepril when we have lisinopril that you're not allergic to that cost us 10 cents. And so there's an enormous amount of pressure to change these things around. Once you start doing this, I mean, we're a victim of our own pressures, siloed healthcare, and that is driving this confusion. My father-in-law 50 years ago followed his patients. He took notes on a piece of paper, 3x5 cards sometimes. He followed patients through. He knew what they got before, he knew what they got there, and he knew what they got after. He didn't have to do all this kind of monkey business. So in that, trying to pay attention to that and respectful of what you really have said, I think one of the key things that we want to do is stop these medication errors. They're clearly the majority of errors that are occurring. They hurt our patients, and that's clear.
I just take umbrage with the use of errors because they aren't errors in a sense.
Okay.
It makes perfect sense to substitute lisinopril because it's on the formulary
Yep.
when I've got them on enalapril most of the time. Now, occasionally they've had
Yep.
maybe not a problem with the enalapril, but a therapeutic failure with enalapril. But that's not very often.
Yeah.
But nonetheless, they can get into trouble if now they go home with the new lisinopril and then they've got a bottle of enalapril.
Right.
And they don't recognize the similarity of the two drugs and they start taking both of them.
Yeah, well, that's what I consider the error. It's our error for not explaining it. So what we do is exactly what Carol, I mean, there's so many points in there. That's the thing. I could talk up here for an hour and these guys are going to kill me. But look, we don't spend enough time arranging these medications before they go. And you can't do it in the last 30 minutes or hour before they're incredibly complex. I mean, patients come in, they've got 10 medications, they've got your medications, our medications. They're not in any mood to explain them when they come through the emergency room. So, 50% of the time there's an error. A lot of the times we don't know the primary provider because they give us the absolutely wrong name. Or we say something, Dr. Jones is your, yeah, Dr. Jones is my primary provider. We send everything to Dr. Jones and we get a note back that says, never heard of this patient. And so the thing is that what we're going to do, I think, is focus on some of the big impact but doable things. This is a doable thing. we need to fix these medication issues. They don't originate with you, they're our problem. We get the patient, we scramble their medications, and we don't give them a good list or a good understanding of what to do and what not to do. In addition, after they go home, we don't check on them to make sure that they've got it. Because, everybody says they've got it when they want to go. But then they get home, just like anything, they explain how the computer works at the store, and you think you go, and then you go plug it in, and of course, the thing doesn't work like it's supposed to, and that's just the meds. And, as I get older, I realize I can't read the bottle anymore. I gotta wear 2 pairs of my reading glasses to read these bottles. So it's no wonder that people are getting confused, and we need something more hands-on. So that's one thing that we are doing. I mean, again, not the whole thing, can't give everybody all the discharge instructions. I mean, they're so complex, there's so much paper and so much material, but I think the meds we're gonna focus in on. And then, one of the things we know is that nursing home care, that is where we get a lot of our readmissions. And when we look across it, we figure how many people come back to us. And I think that's a national trend. It's for obvious reasons. They go out. They can't just walk home. They're not your same-day discharges. They're the people that are going to most likely come back. And so we have launched a new program, some of which some of the folks back at Extended Care I'm sure are going to be involved with Panorama, the rehab facilities, where we do better handoffs. I mean, the handoffs from doc to doc are very difficult to do. I think you'll all recognize we're all very busy to try and make that happen. But I think we can install a care continuum with care managers that make that handoff between us, rehab, nursing homes better. So it's not going to cure everything, but we hope to go where the goal is and reduce the majority of our readmissions. The third thing is, when people look at why these people most of it is get readmitted, most of it is our dysfunction in communication. And we need to somehow improve that. Is this a health information exchange going to happen? I mean, I talked to Dr. Jump, I think it is, from Tenino. I spoke last night with Michael about that. We don't communicate, and our systems are very complex in communication, and so St. Peter is working on how do we get you guys that information in a more timely fashion. And we'd like to give you access to Epic. That way you don't have to wait for the dictated note. You don't have to wait for the signed note. You can look at all their labs, all their reports. We just have to do it in a way that's acceptable to you. And we're working on that. And I'm hoping within the next 6 months we'll have some solution that will allow you to have access to patients' records. And that's a web-based product. So you don't need any new software. You don't need anything. You just need to be able to type in the address for Epic and get an account from us. So again, lots of stuff. Can't fix everything, but I think we've got 3 major efforts going on that we hope will reduce something.
And the Providence system is also part of the Choice Collaborative trying to look regionally, because both St. Pete and Capital Medical Center do serve as regional acute care centers serving people from the broader 5-county referral area, and we know that also complicates the work that both of those institutions do. Dr. Herring, can you tell us a little bit about PSW's most recent initiatives?
What we've been doing for the last couple of years is having our nurses call patients within 7 days to find out how they're doing, any particular problems they're having. We've also been doing an emergency room follow-up program for people who are particularly sick who happen to get discharged, to follow up on them, and also to try to provide histories and physicals for all of our primary care doctors so that they can at least know what's been happening. And that's been variably successful depending on what's available. So next program. Next slide. So if you look on page 10 of your tool kit there, there's a nice slide that you can look at more closely. And what we want to focus on is the red slide, which shows, and I can't read on mine because it's too small, but on these people are at high risk of readmission. And if you look there, you can see that they've been admitted 2 times or more in the last 3 months. They're unable to teach back. There's a section in your toolkit that tells you what teach back is. And they have a low likelihood to follow up treatment plan and a high likelihood of readmission within 30 days. So we are going to focus on these patients primarily, and we've come up with a plan. And I'd just like to share that with you in a little bit of detail. First of all, our utilization management team is already following these patients in the hospital. They make daily visits to the hospitals, and they know these patients. So we think that this is ideal in that they know when a patient is going to go home, they know what the patient has been through, and they can communicate those things to the physicians. Now, they can't communicate to you necessarily because they can't get through to you. So our medical directors, Dr. Fairbrook and Dr. Goen and myself, are going to be calling you when one of your patients is in the red zone and is ready to get out of the hospital. And we're going to tell you why they've been there, how long they've been there, what's been done, what their medications are, and the fact that you need to get a hold of them within 48 hours or less. Also, that you need to start having spaces open, I would say for people who have a high volume of patients in the hospital, like myself, at least 3 to 5 spots a week, maybe 1 a week. And one a day. And if you haven't had someone fill that spot by 3 o'clock the day before, you can fill it. I mean, someone who needs to be seen, then you can go ahead and fill it with another patient. But we have to have spots open for these patients. There are other patients who will ultimately who are going to be in the red zone, who are going to be in SNFs. We don't have a specific plan for them yet, but I think over the next couple of 3 months, we'll be doing the same thing with them. Our nurses are going to be calling all patients who are not in the red zone to find out how they're doing and call them within 3 to 5 days. And we are also going to have these patients in the red zone tracked and be reported to the medical management and QI committee for ideas on how they can be further helped. So this is more of a proactive approach, and I think that by targeting these high-risk patients, we can really help them out in a quality way. So next slide. There we go. So this is our set of hospital admissions from the 11th to the 29th of April. We had 29 admissions, 17 identified as high risk, 2 died, 21 home, 7 to a SNF, 4 to home health, and none to hospice. These patients, of the 18 identified as high risk, these were readmitted in the past 30 days and not identified as the same diagnosis, which Carol identified also. You'll notice that none were on hospice. 23 were full code. So I think we have some work to do here to make sure that all of our patients are presented with the opportunity to identify how they want to be managed, no matter what their age, 65 and up, so that we're not left in the lurch here. Next. We've also drawn up some data for the last year. And if you look at this, we have the readmissions were not as high, not nearly as high as the last month, but there were 9.3% readmissions within 30 days over the last year. There were 213 patients with more than one admission in a year, and which represents 4%, and 546 with multiple admissions. Now, this is planned admissions for joint replacements, cardiac casts, whatever, and observations. So those are a little different, but that represented 15.4% of our total admissions. Next.
Mike?
Yes.
I'm sorry, I'm sorry, I was a little confused between the third and the fourth.
Okay, so the multiple admissions included kind of all categories. They were planned admissions, they were observations. There's a lot more observations going on in Lewis County than Thurston County. Whereas the third category were people who were admitted acutely, unplanned. So the fourth category was a blend.
Okay, so third is unplanned admissions.
Yes, and the fourth category is all admissions.
Planned and unplanned.
Yes,
Okay.
yeah. Okay, next. So we will be undertaking this project hopefully by the 1st of May. So when you hear our friendly voices on the phone, it's not Dr. Herring denying a procedure.
You're insisting on a procedure.
Yes,
He
and
was patient.
we will be having this followed by the Medical Management and Quality Improvement Committee, and we'll be tweaking the system. So as we find that things are not working as well, we'll be trying to make changes. We will, as I mentioned, we'll be expanding this to skilled nursing facilities so that these people who have come from the hospital to the skilled nursing facility, there's a big lag there, and we'll want to be communicating where they are in their continuum of care. So, you know, this is really I think it's a great opportunity for us to improve our quality of care for patients. It's a specific plan, and you know, it's going to have some rough patches, but I think that it will have an impact on our patients getting the best care after their hospitalization, and hopefully not getting into trouble because of problems. Now, one of the other things that I have to mention, since Mike is here, and even if he wasn't here, is that St. Peter Hospital has offered to partner with us to have a medication reconciliation plan for our patients. It's could I think of it as a beta test site collaboration, and I'm really excited about that because they will be using some of their pharmacology residents to make sure that there are no glitches in the discharge medications, that there isn't a conflict, and I think that'll be a great way for us to kind of immediately have an impact on our patients' post-hospital care.
Thank you, Dr. Herring. Dr. Fairbrook, you were going to talk about another PSW activity.
There's a couple areas that we have. In the pre-hospitalization phase, as Dr. Herring mentioned about the ER visits, but we also monitor ER visits to see which ones that are high risk. People have been in too often in the last 2 or 3 months. People may come in with bleeding or fainting episodes. And we'll usually contact those patients to see how they're doing. And we've had opportunities where we've had to contact the primary care physician and ask him if he knew about the admissions on the one hand. And secondly, is there something we can do with our care coordinators to help out the patients that'll prevent those later? The second pre-hospital thing we're working on is a healthcare review consultation. We're working with at the moment, we're working with the oncologist, but hopefully others later. Somewhere along the line, we have terminally ill patients. We are trying to get the consulting physicians to get the primary care people back in the loop to be sure that the patient is educated and make an informed decision about what their healthcare needs are going to be. Do they need a second chemotherapy, a third chemotherapy, or do they need to think about other issues? And we're trying to get them, that part of that consultation will be, have you seen your primary care doctor, be able to discuss these issues? Because we respect the fact that you've seen these people for a long time and can have some input into that discussion. So we're trying to complete that course. I think the second thing I'd ask you to do is look at your standard operating procedures at your office. What happens to the faxes when they come in? On the SoundPath Health ID card is your PCP physician's name. There's no excuse for the hospital not knowing who the PCP is, but we also send fax directly to your office, but we've had physicians who've never seen them. And so what is the standing operating procedure there in your office when a fax comes in from the hospital that one of your patients needs to be admitted? Does it go immediately under your nose? Does it get faxed into the the EMR, never be seen again? So look at what you do in your office. I am a firm advocate of same-day appointments. In primary care, primary things happen primarily, and they need to have access. And so I would second the motion that at least you have one opening a day for those kinds of people that need to come back in, and your office staff needs to know that. There should be no reason to say your next appointment is 6 weeks, we can't have to wait till then. They need to be alerted to how we're doing this differently, and they need to have a part as part of the healthcare team to help get that information to you and back again. I have a comment about the red flag. I agree with Dr. Menen. The doctor-to-doctor handoff from the hospital saying, I've never seen that happen. We've talked about it for a number of years. It never seems to work. You either get a phone tree, one of the other doctors is busy, or one of the other doctors is out of town. So the information coming from the hospital, what's your standard operating procedure to get that information, the discharge summary or whatever, back to the physician, so he's at least aware of it. And what is the staff doing about getting the patient in and having some responsibility to take that on, having leeway from you to say, yes, I need to see that patient, get him in here. So if you can help in your office and your staff can help by realizing what we're trying to accomplish here and how we're trying to get through with that. The same thing is true. We've been working with the nursing homes, especially Providence Mother Joseph Care Center, to try to do the same kinds of transitions when they leave the nursing home and go home, to get you back into the physician's office in a timely manner with the right medication, so you know what happens when they leave there. I think as time gone on, since I've been in the community, it used to be pretty easy because you're always in the hospital, you always admitted your own patients, and you always bumped shoulders with all the consultants. But as hospitalists came in and physicians in the nursing homes take over your care, it's easy to lose track of where they are and what's happening to them. And so we're trying to close those gaps a bit, piece by piece, to see if we can help you and help the patients in this community receive better care.
Thanks, Dr. Fairbrook. Winfried, one of the things that I'm going to ask you, because I know you know the answer, at the last steering committee meeting, a question was asked that Choice staff had actually researched, and that was whether in the 5-county region that includes both Lewis, Thurston, Mason, Grays Harbor, and Pacific, all hospitals were queried about whether they have any sort of rubric to evaluate admissions for the likelihood of readmission or problems in discharge, and if they had a system, if they used it regularly on all patients. And what was the response?
Well, you might be surprised that not every hospital is using a risk assessment tool, risk stratification tool. And those that do, at least some of them do not use that tool consistently. So that was a big aha moment for our team.
Yes. So with that as a lead-in in terms of the opportunity for all of us to work better with our hospital partners, and clearly Dr. Herring and Dr. Fairbrook have described some both new and ongoing and planned initiatives to partner more closely with our local hospitals. Winfried Danke, please tell us a little bit about Choice Regional Health Network and what you're doing in transitions.
Be pleased to. Thank you very much. Let me actually start out with a question. How many of you in this room are familiar with Choice? Would you just raise your hand? So a few folks, yeah. So let me maybe start by just saying a few words about Choice Regional Health Network, which is the organization that I've had the pleasure of leading now for about a year. Choice was founded in 1995, and the mission of Choice is focused on improving community health in central western Washington through the collaboration and active planning of healthcare leaders in central western Washington. The geographic area is defined as a 5-county region, so that includes this county, Thurston, Mason County, Lewis County, Pacific County, and Grace Harbor County. So a fairly large area, and we are a membership organization. We currently have 14 members. The membership is made up of the region's hospitals. All 8 hospitals are represented through their CEOs, as well as the federally qualified health centers. We have also family medicine represented, public health, and behavioral health resources. So it's a pretty broad coalition of executive leaders that are all really interested in how can we move the healthcare in our communities forward by working together. Excuse me. So programmatically, we really work in 2 main areas. One area is what we would refer to as direct client services. We're not a medical facility, but we do run donated care programs. And you might be familiar with Project Access here in this community, Thurston County Project Access. Choice is actually the organization that runs that program from a back office perspective. So we take care of the referral work and work with the providers here in this community to make it possible to provide specialized medical care on an urgent basis to low-income uninsured individuals. We run a similar, much smaller program for individuals with mental health issues. And we also operate a dentistry program for young children in Thurston and Lewis County. The second area, and this is the one that I will be talking about programmatically, is quality improvement initiatives that really look at the region as a system. And we have, for example, worked to develop standardized protocols around cardiac stroke treatment. That's a project that we just concluded. And the project that I will now present to you on, which is what we term the Regional Care Transitions Improvement Project, falls into this category as well. You might also be familiar with the Emergency Department Consistent Care Program. This is a program that now also runs at all of the 8 hospitals in the region and is focused at avoiding unnecessary ED overutilization by individuals that frequently use those hospitals. So enough about Choice. Let me tell you a little bit about the program that I referenced, the Care Transitions Improvement Project. This falls into the category of what Carol referred to as a community coalition effort. And Carol, thank you for your help with that project, and Mariella and anyone else who's involved in that work, thank you, because it truly is a community-wide effort. And it's focused on the idea that what we want to do is we want to help develop a consistent approach to care transitions in our region. Why is that important? Well, it's obvious. You've heard the presentation by Carol. Poor care transitions are a main driver of hospital readmits. So that's why we started to focus on this project. The project began about a year ago with a community meeting. We had representation from throughout our region, probably about 70 individuals. Again, representing a broad range of healthcare professionals, public health, also some social service organizations. And Carol spoke very eloquently and informed us about the problem of readmissions, and then led a group process where we identified and inventoried the efforts that are already underway to improve care transitions in our region, and also to identify gaps, needs that we perceive that have not yet been filled. And we're beginning to dive a little deeper into also the root cause analysis that was mentioned. Earlier this year, we were able to kick off a regional planning process that built on that very first conversation. And it identified 3 main evidence-based intervention areas that the group has since focused on. And those were identified because they are of greatest interest and also have the greatest potential for the region. And they are Coaching, the Coleman method was mentioned before by Carol. That's one intervention area that we have looked at. Multidisciplinary team care coordination. And the third prioritized area is patient-centered medical homes. Now, in addition to those three intervention areas, medication self-management was also identified as something of great importance, and you've heard reference being made to that topic area before, as well as risk assessment. So the basic idea that there needs to be a tool that helps us to focus the interventions on the right people. Since then, we have systematically explored all of these three intervention areas. We've focused on establishing a common working definition of each intervention area. We have then focused also on identifying leading barriers and strategies that we can use to overcome those barriers. And these have been very, very rich discussions, and I see some of the work definitely reflected in the comments of my fellow panelists here on various interventions. We have augmented this information with surveys. It was mentioned that we surveyed the hospitals with regard to risk assessment tools, and we have done a survey, for example, also of agencies that are involved in coaching to understand what kinds of services do they provide in the region. And the idea is ultimately to come up with a type of inventory that could potentially be very detailed so that we really know what is going on and we can build on that as time goes by. At this moment in time, we are driving towards the development of an action plan, and we have identified emerging actions through this series of conversations that we've had. And just from a process perspective, this has been a pretty fast-paced process. We've met every 2 weeks now for the last 3 months. This is a work group composed, again, regionally of a lot of different individuals. Also, I should mention, this is important, the health plans are engaged in this conversation as well. So it's a conversation of providers and payers. And we believe this is really important in order to come up with an action plan that actually has meaning and is supported by all of the stakeholders. And so far, we're doing well. It is definitely a challenging project, and as was mentioned, the scope is rather large, and we have to balance our desire for relatively quick wins with the long-term system change that needs to happen, and that's a tough balancing act sometimes. So what are some key insights here? So far, what I've arrived at is, and this is not earth-shattering, but I just want to put it out there, if we want better care transitions, we need better care coordination. I think that is really at the heart of this project. And given the limited resources that are available, the effort really of improving care transitions needs to focus on the right people, and that means we have to have some type of risk stratification tool that is consistently used. We've had some really interesting discussions about should we have a standardized tool, what would that look like, and we've pulled back from that and said, you know, it's good enough to have a tool. We're not that picky about which one it is, for as long as you use that tool really consistently. Other key themes and questions that have come up, communication, information, transmission, and you've heard this before, is key. And again, when you think about it, if the key to good care transitions is better care coordination, then that means we have to communicate with each other. So data sharing is an issue. Who is doing what is an issue. Role distribution and clarification. And who is in charge of care coordination is also a theme that has really come to the fore. And so is it the hospitalist in the hospital? Is it the discharge nurse? Is it the PCP? It could be any number of people. So who assembles this interdisciplinary care team that is actually a virtual team? It's not a team in a room. But who takes charge of that? And who makes sure that that team follows up after the patient has been discharged? Resourcing, of course, is an issue. Workload issues in particular. There's a lot of behavior change that is required to make better care transitions work. And there's always the question of well, I'm already so busy with what I do, how can I possibly take the time to make this extra call that you would like me to make, or whatever extra step it is? And that's a real problem. So we're just beginning to work that issue. And it was interesting, at one of the recent work group meetings, the health plans actually stepped forward and said, you know, look, we recognize that hospitals are overloaded, hospital staff is overloaded, and we would be very interested in entering into a conversation with you to see what we could possibly do, we health plans, as far as the staff that we have, to, for example, help with this issue of, is there a primary care physician assigned to this patient, and is the physician that is on a paper assigned to the patient, is there actually a real relationship? You've heard that comment here before. So I think there are ways to approach this creatively that leverage the different stakeholders' resources to possibly make an impact there. Next steps, briefly, is we are now taking our emerging actions to the community. There will be a community summit on June 6th in Satsop, 10 to 12. I know that's a tough time for most of you probably to be there, but I would like to extend a warm welcome to you. And then we will go from there, write the action plan over the summer, and again have another community meeting later in the fall where we present the plan, and then subsequently we would move into implementation. And I just would like to use this opportunity to ask you to get involved in some way. I recognize attending meetings is probably not the way to do this, but take a look at the information that is being generated and give us feedback. Send us emails. That is really helpful to us. We are truly interested in bringing the community together and hearing all the different voices, so I would like to make sure that yours is also heard. So with that, thank you very much.
Thank you, Ventry. One of the observations that I would make in reaction to the interest of health plans in perhaps being able to support in one way or another improvement in care transitions, that particularly in the Medicare population, and particularly if they are health plans that are involved in Medicare Advantage, they are also the stakeholder that's going to benefit the most if both quality of care is improved, that improves premium, and if unnecessary readmissions are avoided, which will contribute to the bottom line. And the equivalent of that is really the PSW model for our 4,200 SoundPath Health members. If you look at the investment that we as the financial risk bearer are devoting to this, we have 3 medical directors on a part-time basis who are working. We now are up to, Bev, a staff of 5 nurses and 2 referral coordinators. We also support the Stanford Chronic Disease Self-Management module and offer it to you and all of your patients free of charge. So in terms of the self-actualization and medical literacy and learning how to. So I think to some extent PSW and our taking responsibility with all of you for your patients who've selected SoundPath Health is really a demonstration of the level of effort that it takes. Not that we have it all right yet, but that Dr. Menen's comment about how resource intensive this can be. But thank you to all of you doctors of PSW who have allowed us to staff and try on your behalf, and most importantly on behalf of your patients, to try to figure this out so that your patients get all the care and services that they need. So questions for many of you practice at Capital Medical Center, and Dr. Hipp apparently was unable to join us today. Can any of you speak to the efforts? Dr. Renke, would you mind coming up to the microphone, or can I bring it to you?
Probably a little similar to St. Pete's. I know Capital looks across town.
Because we're videoing this, it would be helpful.
I know Capital's looking at readmissions and all that, but I mean, part of the problem I know at Capital is whenever we introduce these new levels, new EMR, new ERXers and everything, always the quality of care just goes down as the staff adapts, and we're looking at more and more layers of complexity. And I know there's no way around it. The laws, the state, the HIPAA, you have to do it. But just like you mentioned before, when we just got on the phone, we knew the other doctor across, we didn't have any of those problems. Care was much better, way more efficient. And is there anything looking at decreasing complexity? Because we just keep adding and adding. And every time you see that, and I know at Capital, if you look at patient satisfaction, whenever there's a new incentive, it always drops. And I know we don't have a choice. We can go all night on state laws, the Health and Portability Acts, and all these things we're mandated to do. But simple is always better. If you look at nature, always the simple, most elegant answer is always the best, most efficient, and best outcome. But we're just keeping adding complexity.
Dr. Williams, do you know what Providence Centralia is doing? Can you speak to that?
I get calls from the hospitalists. They call me on patients that are being discharged. They'll call me if they have questions about the medicines they were on before they came in. We fax directly to them from our EMR, our records, and it's pretty good, for the most part, a pretty good relationship. They're all docs in the community. Honestly, a smaller community seems to work a little bit better because we know each other pretty well. And so our communication, I think, is pretty smooth for the most part. And then we have access to Epic. One thing that is a problem with Epic, come to find out, is our office staff can't get discharge summaries that has the same information our discharge summaries have. So the doctors have to get on to get the discharge summaries. Our office staff can't get them for us, which would be nice to be fixed, because that would help us a lot, because our staff does get all the information for us. They know a patient's been discharged. We have that information, so when they come into the appointment, it's in the chart, and we have it all there.
Bev, would you like to come up and talk about what your staff is seeing and doing? And maybe while you're coming up, Dr. Dawson, if you wouldn't mind come up and introduce some of the initiatives that you and your organization are looking to promote, and then we'll have a couple of questions and then encourage people to stay after as well. Yeah, Dr. Dawson.
So in the last year, I've taken over a new position of area medical directorship with Extended Care. The vice president and one of the chief marketing directors are here tonight. And we've had some meetings with both Providence and started to have some meetings with PSW, very similar on a bigger level, to try to figure out communication issues between the hospitals and the skilled facilities, hospital skilled facilities, emergency rooms, and the skilled facilities, and to a certain extent also the primary care docs in the community. We've had some meetings with the Sound Path executive leadership. I believe Mariella was with us at that meeting, and one of the things that came up from the chief medical officer of that organization as a primary care doc was the frustration that he had not getting information back, whether that came from the skilled side or the hospital side or any of those silos of care. So we're working right now actively on very similarly trying to enhance those levels of communication by providing whatever resources that we have to put forward that'll work best for the system, and we're trying different things. So there are some national programs that would take a little time to go into, but we're actively working on some of those things now.
Hi. Our nurses have been working for, I don't know, the last 5 years at trying to figure out the key to getting this thing together. The handout that you have, the toolkit from the Washington State Hospital Association, really is a good guide for us because it allows us to set some parameters, and we've internally tweaked that as an internal document so we can work with it, and we're all measuring the same thing and being concerned, it's standardization, it's that good old stuff. And we're finally staffed so that we can take the time to do some of these things. So that's all really good. We need more data and sharing, and we're working towards those goals. And our nurses get into Epic at both of the Prov hospitals. We're awaiting the settling at Capital as they have just implemented a new EMR, and then we plan on asking them to train us also to be there on site and pulling out the information from there. So, you know, it's just an ongoing process. But I keep a note on my desk because I have a nurse that comes in, she's on call, and she's a retired nurse, and she came in one day and called an ER patient who had been in and out of the ER ad nauseum, and found out it was a behavioral health issue, and called the behavioral health case manager and exchanged some information, and called the PCP's office and wrote him a note and got everybody so that we were all working on the same side, and called the patient back, and she left me the note on my desk and said, "I felt more like a nurse today than I felt in years. I really helped a patient." And I keep that on my desk so that when it gets really bad, sometimes I'm hitting my head on it. But it really is, you know, we can pull things together. We know the resources. We have a good relationship with AAA. We have the behavioral health nurses who are great. And we work with the hospitals. So, you know, we keep trying, and so keep letting us try. And we really appreciate it.
The 4,200 SoundPath Health members are really an interesting little beta test site for what can we do collectively and together. But we recognize that the doctors who are part of the PSW network, including the Providence Medical Group clinicians, care for probably 150,000 patients. So not only do we have to figure out how to do well and better with the 4,200, but then what's going to work and what's scalable, so that whatever systems we come up with really have utility and are affordable across the various silos. Not an easy task. We started this out by saying it's a conversation. So now it's your turn. Those that I haven't called up.
ER reports, preliminary discharge summaries, unsigned, signed discharge summaries. My staff has access to that information through Epic as a backup. So that is all great. And there's always that possibility that I don't know about the ones that I didn't get because I didn't get them. But when I see patients a year later, you know, it's going to come up, well, you know, XYZ happened. Well, when was that? Well, it was a little bit after my hospitalization at St. Peter's. And I'm flipping through going, what hospitalization? And I'm looking back. And that doesn't happen very often in the last 6 months or so anyway. So I wanted you to have that favorable feedback. As a family physician, I am struck by the emphasis on go see your PCP. So I've got 2 different cardiology patients, one of whom ran out of his medications, and he goes into congestive heart failure, and he goes in and he sees the hospitalist, and maybe life's just a little complicated, and the cardiologist comes and sees him, and then he's sent out, and please see your PCP in 3 days, see your cardiologist in 2 weeks. Then I have the other patient who's on 5 different cardiac meds, no deviation from the plan. He gets Natracor infusion to get him out of failure because that's what it took, and same discharge instructions. Well, excuse me, this guy's skating on really thin ice because he's on maximal therapy already as far as I, the family physician, see it. He needs to see the cardiologist in 3 days and me in 2 weeks to look for other loose ends. So I think there can be a trap. It's not very common that you're going to see it if there's this sort of blinders on focus on get them to the PCP all the time. I mean, I'm a big believer in the medical home, and my seeing that second CHF patient 3 days later, sure, I can make sure that he sees the cardiologist and that there's a referral in place, but the bottom line is he should be seeing them simultaneously with my visit, you know, not by referral, you know, a week later or something. So I just would want to say watch for that. And then you spoke to, and I would just underscore, if there was some sort of mechanism so that internally, perhaps this would be helpful, is if you could keep track with patients on lisinopril as a formulary substitute for, and then what the guy's home medication is, so that you know that that's why you made that. that is, it's not necessarily a source of problem, but it's a challenge for me when I'm seeing the guy a few days later, and they're just on all these different meds, and I don't know. I mean, you got that message.
I definitely got that message. It's confusing.
Larry, could I just make a comment on your comment about the cardiologist versus the PCP?
Yeah, and I don't mean to single out cardiology.
No,
There's analogous
I understand.
situations with other disciplines.
And my response is, the PCP is a whole lot better than nothing. Because if the patient comes in 3 days and is having trouble, you have, as the PCP, have the ability to get a hold of the cardiologist and say, this guy's in trouble and he needs to be seen, whereas the patient really doesn't. If the patient is, even though they're scheduled for 2 weeks, they can't get past that front office staff. And so I think that, it's an imperfect system, but at least they're dealing with someone who knows a whole lot more than anyone they know and has the connections to get the patient seen if that's necessary. And I know that in these really complex patients, that the primary care doctor is not going to be able to handle some of the subtle complexities that are there, but at least we can move them in the right direction.
I think it'll be interesting when we have figured out this report to report back to all of the committee and all of you about your actual patients by PCP who were hospitalized and how long it was between discharge and being seen by you or a consulting specialist, because again, I think that the data will help inform where the system is breaking, and if there's some people who have better outcomes than others, that hopefully they'll be able to share some best practices.
Issue with the utility of the phone call. Historically, physicians, you would pick up your weekend patients for your other partners, and on Sunday night you call them up and say, listen, I've had Mrs. Jones in the hospital, she went home today, she's on furosemide and so on, and you should see her in the next couple of days. That's not a long phone call. So what I hear us saying is that we have caved because of the immense technology, whether they're phone trees or 2 or 3 personal lines or whatever. The usefulness in a very personal business is personal communication. And I love it when I get a call from a hospitalist and says, listen, this is what to expect. This is the problems we've had. Rather than having the patient come in de novo and possibly have records, possibly not. And by the way, I also agree that the records thing is getting a little better. But this is a personal business. For someone to say to me, it's not personal, it's just business. This can't be our motto. This has got to be, it's personal communications is going to make this work. Complexity, whether it's phones or technology, we got to get around that. I mean, we have to get to a point where we can maintain a personal touch with each other. And let's see, the other thing is that I put before you all is the issue of communication. We all are aware of the immense complex EMRs that we face and the drudgeries in the evenings when we're doing our charts that used to take us 10 minutes. Here again, we are succumbing to technology rather than using it. So what I would put before you, what, if any, effort is going on to build a database which we can all feed off of, whether you're going into a cardiologist office or coming out of the hospital? Dead quiet.
No, well, for me, I hope I didn't communicate that I long for the time that there was communication. As I mentioned, my father-in-law and the continuum of care, and when people communicated and they gathered for breakfast at the hospital, now there's nobody. Communication is difficult. That's what I wanted to imply. Not that it shouldn't be done or isn't. I think that's ideally done. I mean, we just don't talk to each other enough, hardly at all. There are people that come into the community and leave the community that I've never seen before. We don't interact. People don't come to grand rounds. People don't come to these Saturday conferences. We don't know each other. We don't talk to each other. I'm just pointing out that it's there. It's difficult. Not that we shouldn't do it. I think it's the ideal. And all that.
The UM Quality Improvement Committee had talked about inviting the hospitalists, among other people, to come to a meeting to talk about handoffs and what could be done that way. And we're also in the process of building, Tamara and Tony are building a brand-new provider master index, and we'll be asking each of you which EMR you're laboring under and what's your back office phone line, and how can we share with selected partners what you're doing. PSW also has a clinical integration steering committee, not a Clarity steering committee. Clarity is a temporary bridge that may help solve a tiny piece of the problem. And so those of you who are interested in that robust database for clinical sharing, looking at other systems and what the ultimate optimum communication is going to be something much broader than just PSW, and will involve all of our community partners. Dr. Schetzel-Hill has been very patient, waiting to ask a question.
Well, you brought up the issue of the hospitalists, and I think they need to be part of this conversation. I'm working with the primary care department at St. Peter Hospital and Dr. Wagner, and there's efforts underway to try to help bring primary care back into the hospital in some fashion, in particular just the coordination of care and transition of care. I think we're all lamenting the loss of continuity that came with giving up, caring for our patients in the hospital and turning them over to the hospitalists, and that's really what this whole thing is about, I think. We've got more players. I think technology really will play an important role. Everything said, it's very personal. We have to make sure that we're communicating. We had a meeting with the hospitalists involved about this role of primary care, and they were just really congenial in trying to work with solutions. Physicians that have an interest in playing some role. There's a new category of medical staff that's being worked on to provide, I guess it's being termed office-based active staff, where you can be on staff and have voting privileges and so forth, and admit between 10 and 20 patients and have an active role. I don't think I'm interested in going back into the hospital and admitting, but I want to have better communication with both patients going in and going out. I know there's been conversations tonight that I've overheard of how many times do we hear any requests from the hospitalists for medical records on the patients, and it just doesn't happen. Many of us have electronic records, and I think all of us will in the near future. We have great databases with that. That really needs to be tapped for patients going into the hospital. With that comes a medication list of what the patient was on when they went in. That can be used to coordinate what they're on when they go out. Was it an ACE? What were they on before? So that we're not duplicating or getting double entry meds. So anyway, that's, let's get the hospitalists involved. They're part of this conversation.
We are at the scheduled time to close. I know this is an issue that all of you have great passion about, and so I encourage you to continue the conversation. If you had a comment or a question for any one of our distinguished panel members, trap them before they hit the door, and exchange business cards or whatever. I remind you that the Williams Group has been kind enough tonight, as usual, to video our conversation, our first conversation about transitions. And so in approximately 2 weeks, it will be on the website if you want to listen in again, or for your colleagues in the community who weren't able to be here tonight, to bring them up to speed. I would hope that you would encourage them to go to the PSW website and check out the video for the conversation that they missed. And finally, in your packet, right behind the agenda, there is an evaluation form. We'd very much appreciate it, and we'll let you out the door without it, but we'll try to guilt trip you if you don't hand us one of these forms that says what worked about tonight, what didn't, and what are some topics that you'd be interested in. So please dig them out of your folder, and then join me in thanking the members of the panel and Carol for a very stimulating evening. Thank you all, and good night. Grab your forms.